As you're reading my lengthy 2 titles here, I'm going to be sharing you the results of 2 studies that we've done here at the FASD-PN clinic in Seattle. Following my presentation are a number of presentations focusing on the neurodiversity of individuals with PAE and FASD. One of the likely causes of this neurodiversity is the high prevalence of other prenatal and postnatal risk factors that are adversely impacting fetal and child development. When diagnosing FASD, it is never just alcohol. In my presentation, I will share with you how prevalent other prenatal and postnatal risks are among 2,652 patients with prenatal alcohol exposure evaluated in the Seattle FASD-PN clinic over the last 33 years. I will also share with you which of these risk factors, alcohol, illicit drug exposure, multiple home placements, physical sexual abuse, pose the greatest risk. There is a way to begin to address those types of questions. Understanding the prevalence of these other risk factors is critical to the rendering of an accurate diagnosis of FASD, as well as establishing effective intervention plans. For those of you not familiar with the 4-digit codes diagnostic system, here's a graphic summary of how it works. FASD is characterized by growth deficiency, a unique set of 3 facial features, structural, neurological, and/or functional brain damage, and the prenatal alcohol exposure. Each feature is ranked on a 4-point scale from normal, mild, moderate to severe. The higher the rank, the more severe the outcome. For example, if a patient presented with normal weight but height below the 3rd centile, all 3 of the FAS facial features, severe brain dysfunction, and high prenatal alcohol exposure, they would receive a 4-digit code of 3434. The 4-digit code is always written in the order, growth, face, brain, alcohol, so you can quickly look at the code and get a pretty good sense of where the impacts are on that individual. But what is the diagnosis 3434? The 4-digit code identifies 3 diagnoses under the umbrella of FASD. FAS is the most severe, where growth, face, and brain are all significantly impacted. Static encephalopathy, alcohol exposed, is essentially FAS without the physical features, but the same severity, brain dysfunction. And neurodevelopmental disorder, alcohol exposed, is characterized by less severe brain dysfunction. 3434 is one of 40 4-digit code combinations that meets the criteria for FAS, as you can see. So in other words, if somebody was rendered a diagnosis of 3434, it's one of, like I said, 40 codes that qualify for FAS, alcohol exposure, and it is presented on that grid. I think it's important to note that prenatal exposure to alcohol is rarely the only risk factor contributing to the adverse outcomes observed in an individual with prenatal alcohol exposure. As I will share with you today, there are a multitude of other prenatal and postnatal risks that must be taken into consideration when deriving an FASD diagnosis and intervention plan, importantly. The 4-digit code documents and ranks all pre- and postnatal risks and rates them on a 4-point scale, just as demonstrated in this sheet that we often share with families. So what is a 4-digit code really has always been a 6-digit code, to be sure. Presented here are examples of just a few of the prenatal and postnatal risks that we have observed in our clinic over the past 33 years. In addition to maternal alcohol use during pregnancy, there is a growing evidence that paternal alcohol use has the potential of adversely impacting fetal development. I encourage you to attend the talk just on that topic tomorrow. We're seeing evidence of paternal impacts in our clinical population as presented by Emma Manling, our UW graduate student that talked earlier today. Our results look very similar to the results published by Phil May and his colleagues looking in their clinical populations. As you read down the list of risk factors, all can adversely impact growth and cognitive behavioral development, just like prenatal alcohol exposure. There's a lot of overlap in that. Before I share with you kind of the prevalence of prenatal and postnatal risks among this population, let me share with you the sociodemographic profile of this population of 2,652 folks that had come through our clinic. As we have seen for 33 years, there's always a slightly higher prevalence of males coming through than females. Our population here in Washington State and the Pacific Northwest, about 48% Caucasian. The majority of the folks coming into our clinic are between 6 and 13 years of age, but we see essentially birth through the whole lifespan. The oldest was 51 years of age coming into our clinic, and about 15% of the individuals coming into our clinic are birth to 3. When it comes to the FASD diagnostic spectrum across this population of 2,600, about 9% of them had FAS, 31% had static encephalopathy, 52% had the more moderate dysfunction, and then a very important 8% is what I call not FASD but alcohol exposed. This is a group that presents with essentially normal parameters on growth, none of the facial features, brain's just fine, but they're exposed to alcohol. You might think, well, this is going to be the subgroup that had truly a single glass of wine. They're not. Their alcohol exposures, their reported exposures are as high as everybody as the groups with FAS, static encephalopathy. There is something about this particular population. If time permits, I'll try to share that with you. The prenatal risks that we've observed among FASD patients with prenatal alcohol exposure are as follows. About 32% of the folks presenting into our clinic have no or poor prenatal care. 52% have pregnancy complications. 26% premature births less than 37 weeks. And about 60% have parents that also have learning disabilities. Again, these proportions, especially for the clinicians in the room can see, are very high, okay? And before my talk is over, I'll share with you kind of a comparison of those prevalences with the general US population. This is the same data, only this time split out, each of these poor prenatal care, pregnancy complications, split out by diagnosis for what it's worth. I'm not trying to statistically compare any of these, but it's just interesting to see when it comes to poor or no prenatal care that 41% of those with FAS compared to 32% of those with static encephalopathy have that issue going on. So you can see some interesting patterns that are kind of appearing across the spectrum of FASD, including the individuals that don't have FASD. The prenatal risks, the prevalence of these prenatal substance exposures is extremely high in the population coming through our clinic. 73% of the 2,652 patients with PAE were also exposed to prenatal tobacco. 64% were exposed to one or more illicit drugs, with the most common being marijuana. Now that marijuana is legal in Washington state, the prevalence is increasing over time. Again, our patients with prenatal alcohol exposure have been exposed to a multitude of substances, not just one of these. So these bars I'm presenting to are just kind of that one factor and what proportion of the patient population is there. But to be honest, typically the folks coming into our clinic, they have 3 or 4 or 5 of these across both the prenatal and postnatal, multiple factors, all of which are contributing to adverse growth and development of these individuals. And again, here's how it's split out over the course of the different diagnoses. I think you have access to this slideshow, and this is data that's been submitted for publication, so eventually this information will be available to you. Postnatal risks include perinatal complications, also often resulting in the stay in a neonatal intensive care unit. The majority of patients attending our clinic are no longer in the care of their birth parents. Roughly 75% are in the care of other biological family members or in foster adoptive care. Postnatal risks, just like prenatal risks, are capable of adversely impacting the growth and cognitive behavioral development of a child with prenatal alcohol exposure. Once again, here's what it looks like when it's split out across the different diagnoses. Additional postnatal risks are observed in our clinical population include the number of out-of-home placements, abuse, and neglect. Again, we have about 71% of the individuals coming in have disruptive home placements, as in multiple home placements. When you count the number of home placements, only about 24% are in a single home at the time they come in for their diagnostic evaluation. About 60% have been in 2 to 4 homes, and another 16% in 5 or more homes. None of this bodes well for typical normal development. About 30% of our patient population has been physically abused, 18% sexually abused. I've clustered all these together, about 73% neglect, homelessness, violence. You get the idea. There are a lot of other competing risks in addition to the alcohol. The prevalence of pre- and postnatal risks in our clinic population is magnitudes higher than the estimates from the general US population that I've presented here. Clearly, 100% of patients seen in our FASD-PN clinic have prenatal alcohol exposure. That's a criteria to get into the clinic. On the other hand, the prevalence of maternal drinking during pregnancy in the general U.S. population is roughly about 15%. 63% of patients in the FASD-PN clinic report drinking all 3 trimesters compared to 8% among pregnant women in the general U.S. population. Keep in mind these figures for the FASD-PN reflect patients born across 84 birth cohorts from born in 1940 to born in 2024. The prevalence of each risk varies over time. Time does not permit me to share all the trends with you. But there is one I want to share with you. In case you feel like this is a never-ending battle and we're not getting anywhere, we are. Okay, this is data from our clinic. And what it's showing here is that the FASD-PN documents which trimesters alcohol exposure occurred, if known. This plot documents that exposure all 3 trimesters has steadily dropped across our patients' birth cohorts from 1940 all the way to 2024. 87% of patients born between 1940 and 72, before the term FAS was coined, were exposed to all 3 trimesters. Again, FAS wasn't a problem and didn't even know it existed. There was no reason to stop drinking. So a lot of folks were drinking all the way through the 3rd trimester. Between 1973 and 1992, 73 being when we coined the term, in Washington, there's a lot of public health information going on. We're teaching clinicians, the general population, that appears to be working. In 1992 is when our clinic opens up, but we're just seeing a steady decrease across the birth cohorts, which is incredibly ensuring. As you continue to go down this list of risk factors and comparing them to the general U.S. population, you can see again that it's very high when compared to our clinic population or the U.S. population. A second question, so now I've shared with you the prevalence of these other risk factors is high. Which risk factors pose the greatest risk to a child's growth and cognitive behavioral development? Their alcohol exposure, their prenatal tobacco exposure, their illicit drug exposure, no prenatal care, multiple home placements, physical sexual abuse, neglect, homelessness, domestic violence. We've got a lot of competing risks here. To answer this question, we used data we collected in a 2009 FASD MRI neuropsychological study. The study population included 4 groups, 20 per group. We had the full spectrum of FAS, static encephalopathy, neurodevelopmental disorder, and then we also had a control group, typically developing children with no exposure, 8 to 15 years of age. The data we collected, we had MRI data on all the different brain regions, neuropsychological assessments across all of the different domains of brain function. We also had their prenatal alcohol exposures as well as all the prenatal and postnatal other risks, okay? This data that I'm presenting to you, and I'm sure you can't read those letters here, but this is published so you can take a look at it, and I do not have time to go through this line by line, but presented here is a single graphic reflecting the answer to the question, what proportion of brain structural and functional abnormalities observed in children with FASD is explained by their prenatal alcohol exposure as opposed to their other prenatal and postnatal risks? Across the top of this are 14 prenatal and postnatal risks. Alcohol is the first one in the ones you see in black boxes. So we have 2 measures of prenatal alcohol exposure, how many days per week, and were you drinking all 3 trimesters? We also have the sex of the child, tobacco exposure during pregnancy, cocaine, marijuana, any illicit drug exposure. We also have a series of postnatal risks, number of home placements, no longer living with your birth parents, SES indicators, physical sexual abuse. Down the left side, we have the outcomes, starting with all the different ways of measuring the different brain regions from the MRIs, the size of these brain regions, and then a whole list of neuropsychological tests kind of assessing the entire gamut, all the way down to what are the mental health problems that our patient population is presenting with. So the analysis is essentially asking which of these pre- and postnatal risks explains a significant proportion of variance in each of the measures of brain structure and function. Significant risks are portrayed as colored boxes. Okay, so of all those prenatal and postnatal risks, and you can see based on what row they're lining up with, what's the outcome they're describing. You can see that black is for alcohol, brown are where the illicit drug exposures are occurring, orange is a physical and sexual abuse. So for starters, if it lights up in color, it means that particular adverse outcome, in addition with others, contributed along with the alcohol exposure to explain the adverse effect in each of those outcomes along the left side. Then the second question is does more than one risk contribute to an adverse outcome? If so, which risk explains the most variance, the second most variance, the third most variance? The one that's explaining the first amount of variance is typically the strongest risk factor. Here's an example. Let's look at IQ, which risk factors are adversely impacting IQ in this population. So of the 14 prenatal and postnatal risks available for entry into this equation, the number of days per week of drinking during pregnancy explained the greatest proportion of variation, 46% of it, in the full-scale IQ on the WISC-3, and thus was the first significant risk factor entered into the regression equation. But it's not done. It says, oh, there's still room to explain more of the variation. Caregivers' years of education explained the second greatest and statistically significant proportion of variance, another 8%. Put those two percentages together, and now we're all the way up to 54% of the IQ variance being explained by those two variables. We're not done yet. It says there's still room in this equation for another, second alcohol exposure measure, drinking all 3 trimesters. This is going to add yet another 4%. So we now have a total of 58% of the variance is being explained by that. There's numbers in these boxes. You can't probably read them, but if you see it on a better scale, you'll see that if a 1 is in the box, that's the first one to go in because it explains the most. If it's a 2 in the box, that's the second one, and the third one, and the fourth one. You get the idea. And if the boxes are not colored, there wasn't any room for those to go in, okay? This is, and not to over-interpret a single study, but this is starting to give you some interesting results. Let me kind of give you an overview. 1, the prevalence of other prenatal and postnatal risks is substantially high in this clinical population. Prenatal alcohol was the dominant risk factor explaining the largest proportion of variance, up to 53%, across the greatest number of brain structural and functional measures. Individually, each of the other prenatal and postnatal risk factors explained a statistically significant but smaller proportion of variance in brain outcomes compared to PAE. All associations were in the directions you would expect. The more severe the risk, the more severe the outcome. The outcomes were strikingly consistent with the trauma, SES, tobacco, and illicit drug literature. Here's one example that I like to present. In the section here, notice that there's no black boxes here, meaning for these measures of the corpus callosum, alcohol isn't, in this study, contributing towards the reduction in the size of the corpus callosum. What is? Sexual abuse. It's like that's the one in this particular case and I thought, this isn't my area of expertise. Sexual abuse results in a smaller corpus callosum. Is that a thing? It turns out it is. There's a literature on it. Look it up. But what I learned in that literature is they said that it only occurs among girls. So this is a postnatal risk factor of sexual abuse resulting in a reduced size of the corpus callosum. And I thought, well, in my study, I hadn't split out sex. So what if I did that with our data? Look what happened. It's exactly the same thing. There's very little variance in corpus callosum size in the boys that were sexually abused versus those that weren't, but look at the girls. In our study, too, we got the same results as what the literature is projecting. So again, this just helps kind of corroborate things. It's like there's times when we don't get alcohol being associated with it, but we do get the other risk factors, and it's consistent. The tobacco correlations that we found in our data set were exactly what you see in the literature. So by presenting the outcomes in this study as a single colored graphic, one can see some important patterns. Despite the fact that all subjects were exposed to alcohol, alcohol was rarely the only risk factor significantly contributing to the adverse outcomes. And roughly about a third of these outcomes, structural and functional, about a third of the time, alcohol did not contribute at all to the adverse outcome in this study, okay? Not to misinterpret this. The adverse outcomes were explained solely by the other prenatal and postnatal risk factors. These outcomes illustrate why there is a need for caution when labeling a patient's diagnosis based on a single risk factor, especially when multiple other risk factors are present. It's also important to note not all individuals with prenatal alcohol present with adverse outcomes. The majority do, but not everybody. In the clinic, a consistent 8% with high prenatal alcohol exposures present with normal growth and development. Not everyone, it turns out, is equally susceptible to the teratogenic impact of prenatal alcoholic study or exposure. Our twin study illustrated that the effects of the teratogen alcohol can in fact be modified by your general human genetics to the extent we don't fully understand that, okay? So, in conclusion, a better understanding of the high prevalence of other prenatal and postnatal risks and their adverse outcomes on growth and development of individuals with prenatal alcohol exposure will lead to more accurate FASD diagnoses, more effective intervention strategies, and like I said, further illustrates the need for caution when picking a single risk factor and labeling a diagnosis based on that single risk factor, when in fact it's probably some huge combination, or alcohol may actually be the bit player, and the other risk factors might be the more dominant ones. So real caution in doing so. Thank you very much.